Good morning, all. So, everybody have come, totally 15 students, or we need to wait for some more. Who is the class rep? Are you hearing my voice?
Yes, Miss.
Okay. Okay. So, can we start, or some more to join? That's all.
I think we can start, Miss.
Okay. So, just with a brief introduction, I'll just go into the class. I hope you know about the subject. So, subject is 2 credit paper, and the subject is completely surrounding the women's health. So women's health means like starting from birth till birth, in sense it doesn't include the pediatric part, but from the adolescent, then it will go completely till the monarch of a women, or till the uh, climacteric of a women. We will be This subject will be dealing with from the adolescent till the monarch of a women. Okay. So in this part, especially we give more importance to the pregnancy, and it's like the PT role on the during the pregnancy or after the pregnancy. Exactly. Yeah. So practical, I'll be dealing with the practical part. Dr. Deepthi will be dealing with the theory part. I hope you know that. So practical part will be coming very less. So I will not be taking the class regularly, but on and off when she's completing the theory aspect, I will go into the practical aspect. So I know that so far she has completed the first chapter, that is introduction to the anatomy and physiology of the women, especially related to pregnancy. So today we will be seeing about the anatomical factors and physiological factors of the reproductive system. So today, if you are there in the campus, we would have taken you to the FOM skills lab, and there they have a lot of manicures for you to palpate, touch the part, and feel the part. And they have a lot of pelvis and other structures for you to see and observe. Since like you are not able to come to campus, I have just downloaded few of the videos, and this today's class will be through the video, because there is not much for me to talk about it. So that's why I have put everything in the video form. So you can observe the video, and if you have any doubt in between, you can stop and talk to me. Is that clear? So this videos all will be surrounding your anatomy and physiology, whatever she has taken in the theory aspect. So maybe it is just since you are post diploma, it is just a recap for you. Everything will be just a recap for you. Maybe whatever you have learned in your diploma, whatever you have learned in your degree, anatomy, physiology, everything. So it is just a recap. Okay, so don't think that why we are learning the same thing. Okay, so it will be little bit same thing as your diploma. So don't uh, get frustrated about that. Okay, so we will see how you are able to, like in other aspects we will be able to give you more details. So other aspect in sense, when you are coming for the other practicals like an antenatal, postnatal, then we will see little more, and we will be able to see along with the case scenarios. But today's practicals will be a common one, just a recollecting. This will help you to recollect your anatomy and other things. Is that clear?
Yes, Miss.
So we will go into the chapter 1. So the first part is um, So the first part will be introduction about the reproductive system.
So the idea
So can you see this? You are able to see the screen?
Yes, Miss.
Okay, so this is an introduction to female reproductive anatomy. So the idea of this tutorial is not to go into much detail, but to basic elements of the female reproductive trade. So what we're looking at here is a lateral view of the pelvic viscera. So anteriorly, we've got the bladder. Behind that, we've got the female reproductive system. And behind that, we've got the rectum and the anal canal. So the location of this reproductive system in relation to the bladder and the digestive system behind it. So the main parts that I'm going to talk about are the ovaries, which are the primary female sex organ. And then you've got the fallopian tubes, which is this muscular sac, which is where
Miss. Miss the
இதெல்லாம் நிறைய பேர் நிறைய கூப்பிட்டு காசு கிராண்டா காமிக்கிறது அடிக்கணும்.
Miss, the video is not audible.
Lining the cavity of the uterus, you've got the endometrium. So you've got the endometrium here. The muscle there, I forgot to mention this one. And then, like I mentioned before, you've got the curvature, which is the outer connective tissue. That is interesting because it thickens and it disintegrates menstruation. So it's under hormonal influence. So it varies in thickness during the menstrual cycle. So the lower part of the female reproductive vagina. And this is a fibromuscular tube. So those are the anatomical relationships. So the vagina runs between the external vaginal orifice up to the cervix. Got the outer connective tissue there, the middle muscular there. You've got the internal. So, rotating this one around, you can see that the pelvic cavity is lined by this flat sheet of peritoneum on the abdomen. Be aware of this flat sheet of peritoneum which is draped over the viscera and it's called the Thorn ligament. And this sheet of ligament which is draped over these organs forms various pouches. So for instance, anteriorly from this pouch here, the vesica uterine pouch, and posteriorly you can see how this pouch moves behind. Over the uterus. And you can see so that's the very introduction of the elements of the female anatomy.
Hi. Totally the volume was not there. Complete. Okay. So there is a bit of internet problem also today. Okay, now are you there? Are you able to hear me now?
Yes, Miss, able to hear.
So that is about the reproductive system. So here in that particular thing, what we have to see is, so the uterus will be in between the bladder and the rectum. So in this case, all three organs will be in a bony cage. So if any one of the organ is becoming bigger, automatically the space will be compressing. So that's why whenever a woman is getting pregnant, the bladder and the bowel both has to compress little bit for some time. Then later, once the uterus is moving into the abdominal cavity, then you will be able to, then it will be little bit easy, or the space will be okay for the bladder and the rectum. So till that, at least for 2 months, the uterus will be inside the pelvic cavity. Till that, the bladder has to compromise its space. So then, initially, if you see the when the in a non-pregnant women, the uterus will be in an anteverted position. Then slowly, when she's become pregnant, slowly the uterus will become bigger and bigger. Then it will become like a straight. It will come to a vertical position. Then from that vertical position, it will be pushing to inside the abdomen cavity. Exactly. So that is a major thing from the video. I can say that is a summary of the video. So that's why as a PT during the pregnancy, we have a major role in pelvic floor as well as the abdominal muscle areas. Is that clear? So now, like as I said, the three organs will be inside the bony cage. So that means the pelvis also plays a major role in a women, especially during pregnancy. So, as you like in the theory, you might have read about the different types of pelvis. So today, now we will be seeing about the uh, female pelvis, and I'll show you a video regarding that. And in that, they will be telling you about the diameters. They will be telling you how to palpate. They will be telling you how to uh, uh, like how to check whether the pelvic diameter is enough for the normal delivery of the baby, all those things. Okay, so in case if you are able to come back to campus, then we will take you to see or observe the manicure and palpate and do the palpation. Okay.
Briefly review the basic building blocks and navigate as it relates to telemetry. Describe efficient introductory techniques or the relevant portions of clinical telemetry, maintaining patient comfort. Introduce the four basic female pelvic types and apply knowledge of clinical telemetry to the findings specific to each pelvic type. Okay, so first we'll start with the very basic bony anatomy of the pelvis. The three bones of the outer bones are the ilium, ischium, and the pubis. The pubic bone is your tibia, or the symphysis pubis anterior, and the legs have the sacrum articulate posteriorly with the ilium. Two bony projections are discussing clinical telemetry, and these are the ischiospines, which can be seen on the inner medial aspect of the ischial bone, and the ischial tuberosities, which are actually part of the bony pelvis system. That's one of the short video document. The ability to predict the pelvic disorder based upon clinical telemetry is not been brought out over time. For the most part, every woman should be given the tri-related for the obstetrician that desires to offer patients more options than simply spontaneous vaginal delivery or cesarean delivery. Medical telemetry is an important part of patient assessment when considering operative vaginal delivery, rotation of the needle head, and breech vaginal delivery. In the next segment, I will demonstrate an efficient introductory technique for performing clinical telemetry while maintaining patient comfort. You will be doing the voice of course. The initial assessment of the pelvic outlet is by estimating the bias reverse distance. This is done by learning relation
the index and middle fingers of the left hand, which is gently placed into the vagina. The wrist is dropped. The examiner is anteriorly touching the unstable punctuate with the middle finger. This allows the assessment of pelvic inlet and the anterior posterior diameter of the pelvis. For a normal or wide diameter, the sacral punctuate will not reach. For a narrow diameter, the sacral punctuate will reach the middle or even the finger. Next, the hand is rotated 90 degrees at a curvature the same time as palpated by moving the fingers interior. The anterior surface of the sacrum is described as being hollow or flat. The midplane of the pelvis is examined by slightly removing the fingers from the vagina and palpating it forward and hip lock with the pelvis. The spine is described as prominent. At this point, the other assessment of the body part, which is helpful in assessing the transfer of the pelvis is form, wide, or narrow. From the ischial spine to the pelvic backbone and to the assessment, this can be done by holding the internal against the ischial spine and palpating against the lateral ischial tuberosity. The tuberosity is found in the spine. This is a divergent pelvic sidewall, and the tuberosity in the spine is called parallel sidewall, and the tuberosity in the spine, and this is called a peripheral pelvic sidewall. The retropubic angle should not be confused with the pubic arch that is described next. In examining the retropubic angle, the examiner reaches the two examining fingers up on that pubic bone and palpates the posterior aspect of the pubic bone, a superior pubic bone. This will allow us the anterior portion of the pelvic inlet. The retropubic angle is described as wide, round, narrow, or angular. Finally, some pubic arches. This can be performed by palpating the anterior aspect of the pubic bone and estimating the arches of the 120 degrees wide, greater than 90 degrees, but less than 110 degrees, which is long, or less than 90 degrees, which is narrow. This is the final assessment of the pelvic outlet. In 1933, Paul Lloyd developed a classification system for the 4 basic female pelvic types. They are gynecoid, android, anechoid, gynecoid pelvis is the most common pelvic type, representing approximately 50% of all pelvic types.
Okay, now they will show you what are the different types of pelvis. So in female, we have 4 types of pelvis. So the first one is gynecoid.
Gynecoid pelvis is round and spacious throughout, creates an overall cylindrical shape that favorably allows the exterior rotation of the fetal head. This pelvic type is mostly vaginal. A clinical pelvic pelvic inlet of the gynecoid pelvis is associated with the sacral part of the and a retropubic angle that gently sacrum is well firm. The ischial spine is pelvic sidewalls are parallel. The subpubic arch approaches 90 degrees, and the right is normally greater and horizontal. The android pelvis is present in approximately 25% of women. The android pelvis is the most restricted of all pelvic types, owing to the limited space of the inlet and the progressive doubling of the mid pelvis in the pelvic outlet. Arrested descent is most commonly seen at the level of the mid pelvis in the android pelvic type. A clinical pelvic history of the android pelvis. The pelvic inlet is triangular in shape. The diagonal edge is narrow, and the retropubic angle is sharp and acute. Sacrum is almost always flat or minimally curved. The ischial spines are prominent. The pelvic sidewalls are convergent. Suprapubic arch is narrow, as is the bituberous isthmus. The android pelvic type is found in approximately 20%. The anterior posterior diameter is much wider than the transverse diameter. The fetal head often can only engage the pelvic inlet in the occipital posterior position and usually does not rotate. The spacious posterior pelvis transverse diameter. Rotation of the fetal head is not going to occur until the head is on the perineum and the pelvis transverse runs. Unclosing pelvimetry is sacropromontory of the funneling pelvis is reached, and the retrocubic angle is nearly flat. The sacrum is posterior and more flat. The spine is wide, and the pelvic sidewall is divergent. The subcubic arch is wide and flat, and the bituberous is very low. There you have clinical pelvimetry classification of the base of female pelvic ribs. A little bit of practice is real identifying the landmarks of the female pelvis. Start practice with pelvimetry. A little more practice, not just identify your first pelvic pelvis. Always allow your patients the opportunity to try with you. But if you begin to incorporate clinical pelvimetry into your routine obstetrical practice, both you and your patients will have more options available. When you're faced with malpresentation, femur erectus disorders, persistent proximal posterior positions. Thanks for watching.
Okay, so the main reason why we need to look for the pelvimetry is like to decide whether the mother is going to have a normal delivery or she has to go for a cesarean delivery. So if the pelvimetry is normal and favorable gynecoid pelvis, then only we will be able to take the mother to a normal delivery. Otherwise, we cannot take the risk of some of the arrest and some of the problem to the baby. So most of the time, if the mother doesn't have a gynecoid pelvis, they will be taking them for a cesarean section. So in olden days, they used to still try for a normal delivery by palpating, by rotating the baby, by using the hands. All those manual technique were used to bring a normal delivery even in other types of pelvis. But nowadays they don't try for a normal delivery until and unless they have a gynecoid pelvis. So that is the importance of knowing this pelvimetry. So next we will see about the difference between male and female pelvis. So the difference will be according to the shape, size, and it is also according to the other structures like pelvic inlet and outlet. Okay, so just watch this video. Okay. So I hope you are a little bit clear about the anatomy of the pelvis and the anatomy of the reproductive system. So do you have any doubt? Do you have any doubt? Anybody?
No, Miss.
Okay. So the next part is related to the anatomy of the pelvic floor muscle. So this pelvic floor area we will be seeing later only, like during our urinary dysfunction. When we are seeing about urinary dysfunction, we have to see about this anatomy and physiology of the pelvic floor. But still, like since it is also coming in the introduction part, I'm showing the video now. So in this video, so there will be a complete like we have two parts in this video. They will show clearly about the pelvic floor muscles, its attachment, and the ligaments attached to it, the blood vessels, everything will be shown in this particular video. Okay.
This is a tutorial on the pelvic floor. So we'll move space to the pelvis. So you've got the piriformis muscles attaching to the sacrum, right? You can't be that. And you've got the obturator.
Okay, so there is one more part of the video. Okay, just a minute. So in this video, they will explain about the furthermore membranes that is helping the pelvic floor muscle to attach and work properly.
And the perineal membrane. So inferior to the pelvic diaphragm, about try and illustrate the prefrontal pouch. So what I've done is taken a medium sagittal section of this body. So if I just rotate it down, you can see that I'm
Okay. So that's about the pelvic floor. So like this is a brief introduction about the anatomy of reproductive system as well as the muscles, so that it will be easy for you to when you understand the further classes. I know today it must be little boring, but definitely you need to have a recap. That's why I just choose to give you the introduction with this videos. So have a look of the video again when you are reading the slides regarding the anatomy of the introduction slides. Okay, so if you have any doubt, then we can discuss further in the next class. So after Dr. Deepti takes about the antenatal, then we will see about the antenatal practicals. So maybe I'll let you know in the group. So if you have any doubt, you can WhatsApp me also. Okay, so thank you all. Can we end the class?
Thank you, Miss.